My name is Diane Masket. I'm a third year medical student from Rowan School of Osteopathic Medicine in New Jersey. And I'm so pleased to be here with Dr. Amrita Mukhopadhyay, who is from the NYU Grossman School of Medicine, and she is a cardiologist and a clinical investigator. And we are here to discuss her late breaking clinical trial, the Better Care HF trial. Thank you so much for joining
Of
us.
course, thanks for having me.
We're very excited to go through all the details of your trial and learn all about your primary outcomes, and kind of get your perspective on how you think this can be really a trial that could change behavior across all medical institutions. So I think first, I really like framing these discussions to kind of give some background on what exists in the medical literature already in terms of giving alerts to physicians on their EHR, and why you thought this was something that was really important to discover or to look into.
Yeah, that's a great question. So there are a variety of prescribing gaps, and there has been a bit of literature done on how can we use the EHR embedded tools to improve prescribing of a variety of therapies. Um, Overall, the literature kind of shows that when you kind of take all of the studies in aggregate, there is a small but significant improvement. So one meta-analysis reported a 4.4 percentage point improvement across studies. However, when you dig a little deeper, you'll notice that there is wide variability across different studies because there's so much variability in the ways to develop these tools.
Okay.
Um, and, you know, there's just so many different, there's just a wide variety of different types of tools, and some tools are more effective than others. And I think we really need to work to understand what is the optimal timing and delivery of EHR-based tools to really harness their power. And so that was sort of the impetus behind this trial.
Okay,
Yeah.
great. Was there a tool that kind of you used when, you're as a resident and a fellow? Like, was there a tool that kind of inspired this for you, or was it just overall doing the meta-analysis, would you say?
No, so yeah, that's a great question. I think a lot of us clinicians are used to seeing alerts, and we're used to seeing messages. It's nothing new, right? Everyone gets alerts and everyone gets messages. And even if you're not a clinician, you might get push notifications on your phone, for example, or you get emails. These are all things that we all deal with. And I think the thing that really inspired me was the nuisance that I felt from them. So you get so many alerts and they're not relevant, or they're not applicable to that patient, or they're just sort of going rote off of one thing. So that was one thing we really wanted to avoid with this study. And the real impetus here was we have so many patients with heart failure. We have so much data on their ejection fraction. We have their potassium. We have their GFR. We can pull out the patients that really need to be on mineralocorticoid receptor antagonist therapy. But we can pull them out, but then what do we do with that information, and how do we tell our providers in a way that that they can that won't be a nuisance or annoy them, but will actually help them. So I think one of the things that really inspired me is when I'm taking care of a patient in clinic with heart failure, for example, and trying to decide what therapies they should be on. I'm clicking like 4 or 5 different places in the chart. I'm looking at their blood pressure, I'm looking at their ejection fraction, and what was their potassium, and I have to think about all of these things in one place. And it would just, part of the impetus of this type of system was, can we pull all of that stuff into one place and really bring it to the provider's attention so that they know.
Yeah, so really to increase the efficiency of it so that you're not clicking all over the place. From my understanding, it's a 3-group clustered randomized clinical trial with over 2,000 patients, which is really a huge number of patients. Can you give us an explanation of the 3 separate groups in your trial, and what you did for pilot testing?
Absolutely. So just stepping back a little bit, because I don't think we covered this yet, but the clinical picture for this study was heart failure with reduced ejection fraction, and we specifically focused on mineralocorticoid receptor antagonists, or MRA therapy. And the reason for this is MRA therapy, even though we know it saves lives, it's vastly underprescribed throughout the United States. 65 to 75% of patients who could be on MRA are not on it, and closing this treatment gap could save over 20,000 lives per year across the United States. So that was the impetus for choosing MRA therapy. And then to sort of circle back to your question about what we did in the study is we did what's called a cluster randomized design. We had 3 arms, one being the alert, one being the message, and one being usual care. Cluster randomization basically means that all patients are randomized based on the cardiologist that they see. So if there's all patients seeing the same cardiologist are assigned to the same arm. And we had 60 cardiologists in each arm, so a total of 180 cardiologists. And then, like you said, we ended up with over 2,000 patients in the study. As far as the development of the interventions, we did a very long process of semi-structured interviews that were one-on-one with physicians, similar to like what we're doing now,
Okay.
as well as pilot testing. So there was sort of a development phase that involved semi-structured interviews,
Okay.
and then working with with our IT folks to make sure that there was a constant feedback loop between what is useful for the cardiologist, what do we want to see in our interventions, and then going back to IT and seeing is this feasible, and then going back to the cardiologist saying this is what's feasible. So it was a long process of development. Then we did pilot testing at 2 separate practice sites,
Okay.
where we piloted the interventions, and then again did further semi-structured interviews, and then ended up with the interventions that I showed today and that we tested in the Better Care HF study. Yeah.
Okay, so those are the 3 separate groups, and to kind of dive in a little bit more there, were you always planning on doing 3 groups? Like, did you know that you were going to do an alert, a message, obviously the control? Was there ever a time during the development where there was possibly going to be another group? I don't know if there's between a message or an alert or some combination of the 2. Were you guys ever kind of toying with that idea?
I think the combination of the 2 would have been a very hard sell for physicians. I think it's hard enough that we're going to be getting an alert.
Yeah.
It's hard enough that we're going to be getting a message, but getting both, I think, would be a pretty hard sell.
Yeah.
Just anecdotally, and myself, I don't know if I'd want both an alert
Both-
and a message.
yes.
So we never really thought of doing both together.
Okay.
Although that is an intriguing idea that one could consider, and perhaps there might be some sort of synergistic benefit.
Yeah.
But I do think that's like a slightly harder sell than just one or the other.
Yes.
I will tell you, the more arms that you add to a study, from an analytic perspective, it does become a little bit more complicated. And that's something that I think this trial sort of showed me. So if anyone sort of takes a look at our paper and looks at the subgroup analyses, you'll notice there's 3 different interactions with every single 3 different results for every single subgroup, which in a 2-arm study would have just been a single comparison. So I think the more arms you add, the more complicated it becomes, and it becomes a little bit harder to interpret.
Okay.
So that's sort of just more of a logistic reason why we didn't do it.
Yeah. Thank you for giving that context and also giving a little bit of insight into running these big clinical trials, because I think that's a big part of us being here right now is to get any type of insight we can from you in that context. So just carrying on with the explanation of your primary outcomes would be really interesting. In your words, kind of, were you excited with what you saw? Were you surprised? I think just tell us what the primary outcomes were and your initial thoughts on them and how you think it can change clinical practice.
Absolutely. So our primary outcome was % of MRA eligible patients with a newly prescribed MRA. So all of our patients, which we hadn't talked about earlier, but all of our patients were they were not prescribed MRA therapy, and they were really highly selected to be patients who would potentially benefit from MRA therapy. So our primary outcome, I was very excited to see our results. We found that the message significantly increased prescribing as compared to usual care, but the alert more than doubled prescribing as compared to usual care. And that, I think, that was, in one way, it was surprising because there are so many different EHR interventions out there, and a lot of them do show sort of a smaller impact. And so it was very exciting to see our results, which were a relatively large impact.
Mm-hmm.
Yeah.
And is this translatable across many EHRs? Were you just using it in one? Do you think it could be rolled out in a lot of different systems?
That's a great question. So we conducted our study across NYU Langone Health. It's a very large health system with specifically cardiology practices, we have over 60 cardiology practices, and they all function under a single integrated EHR using Epic. And so that was one advantage that we had to we just program it in one place and it goes everywhere. I do think most EHRs do have alerts and messages, so I think there is some generalizability to our results in that way, especially they might not call them alerts, and they might have different names for them, but they kind of have the same idea of showing something at the time of visit versus showing something in between visits. So I do think the general concept is somewhat generalizable, but I would say that with any study there is limitations in generalizability. So.
And as you've worked with so many physicians on the pilot testing and then of course with running the trial, what was the feedback kind of during the trial? Were you always communicating with the physicians and understanding how they, there were 2,000 patients, so that's, as you said, 180 physicians. Kind of what was the feedback from them about the utility of the alert? And I would love to see how that is generalizable to other places.
That's a great question as well. So I'll tell you, in the pilot testing, we got a ton of feedback, and we really adapted. So there's sort of the concept of how adaptable is your intervention. It's a concept in implementation science. So in the pilot phase, we decided this intervention is going to be very adaptable.
Okay.
The trial phase is really to test the efficacy. So we did not change the alert during the trial phase, for example, and I was actually blinded. I did not know which physician got which intervention.
Okay.
Or
Great.
a patient. I mean, I didn't even see the patient. So.
Right.
But for example, if I ran into a physician colleague, I did not know if they were in an arm
message
or what
alert.
yeah. So we are collecting survey data.
Okay.
At this time to get some more feedback. From that end, but most of the so we did a lot of qualitative work up front to kind of get at those questions that you're asking of how acceptable is this, how feasible is this in our system, and how appropriate is it. I think in this context we have shown that that an alert was superior to a message. I don't think this means, though, that we should just toss messages out. I do think that, one, the message was effective, and I do think perhaps there are other contexts where the message might be more effective than alert. For example, if you are in a health system that provides time for panel management or time or resources for panel management. So the message was really using a concept I just mentioned called panel management, which is basically where you're trying to take care of an entire population of patients together, either in this case for a physician, but could also be at the practice level or health system level. And so I think part of the reason why it might be potentially more effective in another setting or context is if you have, for example, resources devoted to panel management, such as physician time that's specifically devoted to panel management, or support staff that can call patients using panel management as an approach. So I wouldn't say toss it out completely, especially because the reason for testing both of these is the message does have at least a theoretical advantage of not interrupting workflow and not being, I think most clinicians can relate to having sort of too many alerts or alert fatigue. So that was sort of the impetus of testing the message. But yes, I do agree. In this context, the alert was definitely superior, and I'm looking forward to, expanding it.
Yeah, great. Well, thank you so much for joining us here with the Fits on the Go initiative. If you would like to see more videos like this, you can go to youtube.com/fitsonthego.